Now I invite Dr. SHAIL VASAVADA. Everybody knows him. They are the masters in the pediatric cataract management, and they are since so many years. The Raghudeep is the one of the pioneer in research work in the pediatric cataract. So let's hear from him how they are going ahead with the pediatric IOL power calculations. Dr. SHAIL VASAVADA.
Thank you very much, Dr. Twinkle sir, for this for inviting me in your wonderful course. And fortunately, I'm going to talk something where we don't need all of these expensive instruments, the biometers, the new formulas. Not too much of knowledge is required. And I think to make a child happy, the easiest way is to just give him vision. They are far less demanding for one diopter and two diopters of error. At the outset, I do acknowledge the support of Dr. Deepa Agrawal, who handles our pediatric department at Raghudeep Eye Hospital. And we do receive research grant support from Alcon Laboratories, but has no financial relevance to this talk. In children, determining an IOL power is one of the major challenges because the eye has only started to grow. So it's not a mature eye in terms of development as well as its growth. And there are three major issues that we look at. First is how do we measure these eyes because these are uncooperative patients. The formulas that you use and what refraction do you target, keeping in mind their growth that is going to come. As far as the biometric measurements go, the basics of keratometry and axial length are something that we all would want to get as accurately as much as possible. And of course, for children less than 3, 4, or 5 years, also sometimes they do not cooperate or allow us to do any measurements on the sitting based equipments like a biometer or a topography or anything. So generally we do the examination under general anesthesia, where a handheld keratometer, now plenty of good ones are available, is used to measure the axial length. Always be careful that not too much pressure is put on the lids with the speculum or the fingers, whatever you're using. And for older children who cooperate, you can use the equipments that you use even for adults. If you want a rough brief idea of the keratometry with age, this is the normative database, and typically the cornea is very steep when the child is born and typically tends to flatten out as the child grows. As far as the method for axial length measurement, immersion is definitely preferable. Immersion can be challenging in very small children because the general normal Prager shell that you have for the immersion is too big for most of the children less than 1 to 2 years of age. Therefore, you may have to get it modified or get it made locally so that it fits properly in a small eye. Contact is something that should be avoided, even like we know in adults, but particularly in children, as this paper and in the very early on period, now almost more than a decade old, had shown that contact in children particularly leads to at least a much shorter axial length compared to even when we measure amongst adults. Optical biometry, as has been highlighted, would be ideal for older children. Coming to the formulas, and in most of the presentations that we heard so far, it's sort of now universal that the Barrett universal formula works well across all ranges, across all different types. In children, there is no consensus, and therefore you see several publications, and each has their own recommendation. So one suggests Holiday 1 is better, some would suggest Hage's SRK2T, Holiday 2, etc., so on and so forth. And that's because there are several multiple factors involved in such eyes, whether it was a unilateral cataract, bilateral cataract, associated with microphthalmos, no microphthalmos, so on and so forth. So therefore, there is still no consensus as to which is the most accurate power. And we did our own data analysis, and in our hands, we found the SRKT and the Holiday 2 to be working to be relatively better compared to the other formulas. We are also analyzing our data with the Barrett's Universal, but at present the SRKT and the Holiday 2 are our personal preference. And what interestingly, most of the studies, including our study, found that personalizing lens constants like we do for adults doesn't seem to help much in pediatric eyes. So our choice at the moment is for this. Maybe with the analysis with some of the newer formulas, this may change. Target refraction. Now, this is the most important question. How do you correct the eye completely? Don't correct the eye completely. So the two options are: first is you attempt, and like we do for adults, go for emetropia. Do not undercorrect, overcorrect, do anything. The advantage of that is that immediately the child is likely to see better. So lesser chances of refractive induced amblyopia, but a very very high chance that the child will end up being extremely high myopic as it grows on, and this is particularly true for very young children. Less than this all mainly applies to younger children. For children more than 7, 8 or 9, these things really may not matter very much. So the other option is to leave behind some hypermetropia, what is called as undercorrection, which has an initial challenge because the child will have to wear relatively higher hypermetropic glasses immediately, but the chances of developing extremes of high myopia are less in the future. So the consensus amongst most pediatric cataract surgeons is to follow the second strategy, that is to leave behind some residual hypermetropia, and how much is debatable. So the age at surgery is an important factor in determining the rate of axial growth of the eye, and there have been studies to show that in the fastest phase of axial length growth is between 0 to 6 months. So if you are operating the congenital cataract say at 3 months, you have to think of more undercorrection compared to if you're operating at 1 year or 2 years. There's a slower infantile phase from 6 to 18 months, and 18 months onwards is a relatively safer time where you don't expect extreme jumps or extreme prolongation of the axial length, unless, of course, the other eye is also myopic. This is a normative database to show the normal age-related axial length growth among children starting. So the average axial length at birth would be somewhere close to 19 millimeters, which stabilizes or grows significantly in the first year, as you can see, and then the growth is much slower, particularly 2 years onwards. So it's higher in children less than 1 year in age. It's higher in pseudophakic eyes than in aphakic eyes. That's also something that we found in our publication where we did a randomized trial comparing bilateral aphakia versus bilateral pseudophakia, 5 years follow-up. And definitely, as understandably, the rate of axial length is far higher in a unilateral pseudophakia, which means a unilateral cataract, which is likely to be anyway the weaker of the two eyes. And visual axis obscuration or PCO doesn't seem to affect the rate of axial length growth. So the key point or the key consensus amongst all pediatric cataract surgeons is to undercorrect or leave behind residual hypermetropia. And it depends on the age of the child, the axial length, and the laterality. And the like we discussed, if in a unilateral case, the challenges are more for two reasons. One is if you need to look at the refractive or the axial length status of the other eye, whether the other eye is already very myopic for a normal axial length, I mean normal age for the child, you are more likely that this eye is also going to grow more myopic. But the other difficulty with unilateral cataract is that you don't want to create an extremely high level of anisometropia between the two eyes. So unilateral cataracts are a real challenge. And there are several guidelines as to how much to undercorrect or what power to use in the early on period where only axial length was used as a criteria. The Dahan's guidelines suggested fixed powers for the fixed number of axial length, and they suggested an overall undercorrection of 20% based on the axial length alone. But as time progressed, we realized that axial length, keratometry, age, all of these factors play an important role. And this was another important paper which suggested by Plager and group, which suggested that for younger children, you undercorrect more. And as the child grows older, you undercorrect less. However, this was again for children 3 years and beyond. And the real challenge comes in children less than 1-2 years of age. So Dr. Trivedi, Dr. Rupal Trivedi, Dr. Ed Wilson and their group studied for children even less than 2 years, so 1 year and above. So therefore, for 1 year, they suggest a target refraction of +6 and reducing as the time goes on. From our own data set and our own analysis, we generally don't have a fixed number in mind. We do an undercorrection percentage based on what the calculation formula suggests us. For children operating under 3 months of age, we undercorrect the power by 35%. 30% for up to 6 months, and keep reducing as the child grows on. And anywhere beyond 6-7 years of age, we do not undercorrect very much significantly. So by undercorrection, what we mean is, say for example, if it's a 9-month child and the metropic IOL power is 32%. So if you undercorrect by 25%, that means you're going to end up actually implanting a 24 diopter IOL. Just a word on toric IOL in children, and we have found that older children who allow us good measurements more than 7-8 years of age, the astigmatism has been shown in several normative databases to be stabilized around 5 to 7 years of age. So you don't see a very major shift in astigmatism or corneal curvature beyond 7 years of age. And this is something we published a couple of years ago, our outcomes of toric IOLs in older children more than 7 years of age. And we found significant reduction in their refractive astigmatism, because remember, astigmatism is one of the leading causes of amblyopia, and you can do a toric IOL even with a PCCC being done inside the eye. The IOLs remain stable. So we have found it to be an important tool for combating amblyopia in older children, and so far it's been the largest series of children with toric IOLs. Multifocal IOLs is something that we discourage, because here our aim is not refraction, our aim is to give good quality vision. And it's very surprising that it's only we grown-ups who are so concerned about glasses. Children, even if you give them +12, +15 glasses, if they can see well, they will adapt it so easily that getting children to wear glasses is generally never an issue. With the advent of extended depth of focus IOL, maybe in older children, this is something that we may be considering in the times to come. But as of now, we have no experience to really talk about it. So to summarize, IOL power calculation in children is very challenging, and the reason for it is that it is extremely multifactorial. And I think there is no one fixed recipe, one fixed formula that works well for all eyes or for all children or in all practices. And we need to look at each eye or each case individually, keeping in mind all of the factors that we discussed about. Thank you so much once again for the patient listening.
Excellent presentation, Dr.